Given recent events, I think it would be helpful to go over some of the evidence that exists around the risk of COVID transmission in dining establishments, just to understand why that's something that experts have been advocating with, I think, consensus for action to improve community transmission. So quite a bit of general information that's now all supporting the fact that places that are indoors with larger crowds of people who are unmasked are higher risk. We talked about the CDC universal face mask scientific paper that recently came out. In addition, the evidence of aerosol transmission, which is heightened indoors. In some instances, studies finding that a 20-fold increase or more in terms of risk of indoor versus outdoor environments. And just looking at it from a common sense perspective, restaurants and bars are really two of the only venues that combine all three of the 3 C's that we're trying to avoid, which is close, prolonged contact with people in a confined space and with crowded conditions. And again, if one thinks about restaurants and bars, you can understand they have one of the highest densities in terms of people per square feet of any place in the community. So there aren't actually as many epidemiologic studies looking specifically at restaurant risk as you might think. One of the reasons is that in the US, we simply don't have the contact tracing resources to be able to identify clusters, except in very special circumstances, such as weddings, parties, et cetera, where people can easily identify that as a risk factor, and it's easy to get an attendance roster, whereas it's pretty difficult to track down everybody who was in a given restaurant or a bar at a certain point in time. And so finding all of those potential contacts and tracing them becomes incredibly difficult. In addition, many of the countries that have been able to do more extensive contact tracing have had closures or restrictions in restaurants and bars, and so have not necessarily gotten as much data. But the data that do exist document a strong association between restaurants and bars and exposure to COVID, and there's a little bit that I'm going to cover here. We'll point out that none of the data that I'm going to refer to here is modeling data. There's additional very good modeling data, but apparently that's not something that we're interested in. So we'll look at only true epidemiological data. This is a study that was published in Clinical Infectious Diseases, looking at over 1,000 people in Maryland, and it found that one of the highest risk associations was people who frequented bars and restaurants. As you can see, almost a 10-fold odds ratio compared to people who did not have COVID. The other high-risk venues were public transportation, gatherings over 10 people, and attending worship services. So again, places where you're in close contact for prolonged periods of time in crowded conditions, and many of them without masks. When you look at additional studies, this was a study that was published in MMWR that looked at over 800 people in 11 locations across the country. We talked about this, I think, several weeks ago, but you can see here that people frequenting restaurants had a much higher association with COVID, or at least COVID patients had a much higher association of frequenting restaurants and others. And particularly if you looked at restaurants where few of the patrons were wearing face coverings or social distancing, that association or odds ratio went up many-fold, as you can see there. That was 9 times the number of people with COVID attended restaurants with those conditions. And you can see here that restaurants and bars and coffee shops were the only exposure in the community that had a statistically significant association with COVID, and restaurants had much higher than bars or coffee shops. Cluster investigations in Hong Kong, which again has one of the most sophisticated public health infrastructures, showed that the largest clusters that Hong Kong had witnessed were either linked to bars or weddings, and in one event, temple, but bars, as you can see, had by far the most associated cluster cases with them. And then finally, an analysis of clusters in Japan, which occurred early on during the pandemic, again, when many restaurants and bars were actually closed. But you can see that nevertheless, outside of healthcare facilities and long-term care facilities like nursing homes, restaurants and bars accounted for the largest number of COVID-19 clusters in Japan, representing 16% of the clusters investigated. This was a single cluster investigation from Guangzhou, but in China, but shows the specific risk of indoor dining where you are seated in proximity to people who are not masked and potentially sharing the same air for a long period of time. So these were families that were dining together in a particular section of the dining room for around an hour, anywhere from 53 to 73 minutes. And you can see that one single diner who was infected caused 9 secondary cases from that exposure, all within the same airstream from that air conditioner. And people who were not within the same airstream, which was a pretty confined and discrete area of shared air, had much lower likelihood of being infected. Finally, one of the few cluster investigations that has been done around restaurants or brew pubs in Lansing, Michigan, showed in June a cluster that was associated with 192 community cases from a pub that reopened on June 8th and had an outbreak that began several days after that. Of note, 27% of the cases identified in this cluster were asymptomatic, and you can see the primary cases were almost all in young people, all in people under the age of 29, and this is a college town, so it was a large number of college students around for the summer. And then you can see, similar to the phenomena we've talked before, secondary cases began to migrate into different age demographics, with the 5% of cases in people at high risk over the age of 60. And because people are apparently willing to argue with me that a brew pub does not equal a restaurant, this is what Harper's looks like. It looks like just about every other restaurant with a bar in Omaha or Nebraska that has a pretty mixed patronage. So this is the trajectory that we are on right now. As you can see, our case counts continue to rise precipitously, and now our death count, as predicted, has begun to catch up in terms of its trajectory. Our hospitalization rates are still doubling between every 2 to 3 weeks. The latest calculation I have for both the state of Nebraska and the Omaha metro areas, that's doubled in the last 17 days. And so this is what we're looking at. These are curves of cumulative deaths from the pandemic in the US. On the left are the states which experienced the large waves in the spring, and you can see New York City is that dark line that is highest. New York has reached about 2,800 deaths per million now, but you can see almost all of those were accumulated within the first 3 months. And the second graph on the right is a collection of states that have experienced a summer or fall surge, and those dotted lines, which I've blown up here on the right, are Nebraska and South Dakota and North Dakota. And you can see that those 3 states have about the highest trajectories of increasing deaths of any state. North Dakota and South Dakota almost going straight up now, mirroring what New York City looked like in the fall. And then Nebraska, we are very close behind, a couple of weeks late, as our curve is beginning to bend up towards a skyrocketing trajectory. So the reality of that means that even if we are to eliminate transmission today, we will experience another month of increasing case counts. As you can remember from our inflection lag discussion, it's about a month delay from cases to actual deaths being counted. And so if you look at that trajectory and carry it out for another 30 days, we are clearly going to be well above 1,000 cases, or 1,000 deaths per million when we get to that point. Even if we were to eliminate transmission completely today, the reality is that we haven't done the necessary things to reduce that transmission. So our rate is going to continue going up, and within the next 45 to 60 days, we'll be approaching the levels of New York City, and that's going to get us to those thousands of deaths in Nebraska that we've discussed. So unfortunately, that trajectory is not changing, and that also means that hospitalizations following a similar curve will result in overwhelming numbers for our health system within the next few weeks. That's all I have.